First, let me start with many thanks to Professor Kotsis to inviting me to this important meeting. And so in the next few minutes, I will talk a little bit about arterial stiffness in resistant hypertension. This is maybe one of the largest meta-analyses related with the topic of resistant hypertension. More than 91 studies with approximately 3 million people with hypertension on antihypertensive drug therapy was studied, and in reality, in general population, the prevalence of true resistant hypertension is approximately 10%. Of the apparent resistant hypertension, approximately 15%, and pseudo-resistant hypertension, approximately 10%. So, of course, this is globally, but of course, we have some different number when we talk of specific disease that the patient had. And you can see that the prevalence of resistant hypertension in special group like chronic kidney disease or obesity or diabetes is significantly higher than into the general population. So related with prognosis, we have some new data from the Spanish registry that was presented by Professor de la Sierra during the last Congress of the European Society of Hypertension this year in Milan, with more than 10 years follow-up of the patient on the Spanish registry. So first we can see what is the prognosis of resistant hypertension versus controlled patient, both in terms of mortality and cardiovascular mortality. So it's approximately double with hazard ratio of 22% increase of the total mortality and 37% increase of the cardiovascular mortality. This is important when we compare true resistant hypertension with so-called pseudo-resistant or white coat resistant hypertension. Once again, the patient with true resistant hypertension had increased total and cardiovascular mortality. And last but not least, the special group of so-called refractory hypertension who need more than 5 drugs, they also had increased total and cardiovascular mortality when we compare them with the patient with true resistant hypertension. So very important data. And of course, apart from the risk factor profile and the duration of hypertension, which are important risk factor of having resistant hypertension, at the pathophysiological level, we have two important issues. The first is volume expansion, and the second is vascular remodeling. Both of them contribute to the resistance of hypertension. And those things are closely related. And here you can see that with slight volume increase, with the water volume retention, if we have increased vascular stiffness, it will cause a large increase of the pressure, respectively a large increase of the blood pressure and more resistance to treatment. Saying that, in the new guidelines of the European Society of Hypertension, we have a section from true resistant hypertension with the definition that we know very well, and the drug therapy that is given and that is recommended for the majority of the patient, but also very important question related with the diagnosis with the proper use of ABPM, with exclusion of adherence, which is an important part of this, and exclusion of secondary hypertension, which is mandatory of all the patients with suspected resistant hypertension. And of course, what is more important, we have a new updated treatment algorithm based first of the eGFR. In the last guidelines, we have mentioned only spironolactone, but in reality, if the eGFR is more than 30 milliliters per minute, we may use also a beta blocker, alpha blocker, or centrally acting agent. And something which is relatively new but important, renal denervation as a complementary option in these patients if the eGFR is more than 40 milliliters per minute. And what is very important with the patient with reduced eGFR, we have new data on chlortalidone and loop diuretics, and once again, a new algorithm that must be applied into the treatment of those patients. Of course, the possibility of renal denervation is something very important, and during the last year, we have several new generation trials that clearly show the efficacy of this method of the treatment of the patient with true resistant hypertension, both in patients without or with multiple drugs. And of course, one of the main challenge here to face is who of the patient will respond. And this is something that is black box that is every time mentioned during all the lecture related with renal denervation as a new therapeutic option. Of course, we may use several biomarkers. For instance, Felix Mahut clearly showed that the patient with higher plasma renin activity, they respond very well to the renal denervation versus those who doesn't have this biomarker. And once again, the patient with higher heart rate, they respond very well to the renal denervation. Of course, those are important data, but they both came in the patient group without antihypertensive medication. So other part is to see what's happened at the level of the arterial system. And of course, very important data came with the assessment of arterial stiffness. Here we have some data with the invasive pulse wave velocity measurement, but also with non-invasive technique like applanation autonometry. And this is a very important trial which clearly showed that in such a difficult patient group like patient with isolated systolic hypertension, by using invasively measured pulse wave velocity, we can select a group of patients who will respond better to the renal denervation. In opposite, if the parameter is very high, so we will have only a marginal decrease of the level of the blood pressure after renal denervation. And this is the same philosophy Thomas Weber, which is the actual president of the Arterial Society, clearly showed this by using augmentation index and reflected waves, that once again, the patient with lower value of these parameters, they respond very well to the renal denervation. So this is our experience in my institution. We are Excellence Center of Arterial Hypertension of the European Society of Hypertension in St. Anna University Hospital in Sofia. So normal protocol of the follow-up of the patient before, during, and after renal denervation. As Nebojša mentioned, we measure CAVI index before the procedure, but also during the follow-up. And please note, approximately 13% are the patient with false resistant hypertension. But after that, it's possible in approximately 1/3 of the patient to have a good correction of the therapy with all the drugs that we have. Of course, it will increase the number of the drugs, but after that, we will have a good response, not only of the office blood pressure, but also of the whole 24-hour period, and especially during the night. Finally, approximately half of the selected patients will be into the group of true resistant hypertension in which renal denervation was provided. And this is, in my view, important just because if the CAVI index or the arterial stiffness is lower, you may expect very good result of the renal denervation. In opposite, if it's higher, approximately 20% are the patients who will respond, and here the responders rate is related with more than 10 millimeter reduction of the 24-hour systolic blood pressure. So finally, this goal not alone with the reduction of the mean blood pressure, but also the blood pressure load is reduced. and we have some improvement of the blood pressure variability into this group of patients. So this is my last slide. So of course, resistant hypertension is a risky condition, high total and cardiovascular mortality. We have new and updated algorithm of treatment of this patient according to new guidelines of the European Society of Hypertension. And my hope is that with ABPM, we have some biomarkers that may give us the opportunity to detect which patient will have a good result of the renal denervation, but a part of ABPM, the assessment of arterial stiffness is very important, initial and follow-up part of all the management. Thank you for listening.